Just a quick funding disclosure before we get started. This project was supported the project described in today's webinar was supported by CDC funding. So as you get settled, if you don't mind just popping your name, your title, role, and your organization in the chat, we'd love to get to know who's here on the call today. Okay, let's introduce our speakers for the day. So my name's Annie Evans, and I'm the Director of Preparedness and Disability Integration here at ASTHO. I'll be facilitating today's webinar, but I'm also joined by Maggie Niels, also from ASTHO, and two of our fabulous consultants on this project and partners in this work, Kelly Chester from Thought Bridge and Erica Osthoff from Angle Consulting. So welcome everyone, and thanks for your time today. All right, we'll go through a quick agenda for today's discussion. So we're going to kick things off with an overview of this Defining Disability project. Then we're going to briefly go through an overview, a very high-level overview of the National Syndromic Surveillance Project for which this definition of disability was developed. Then we will discuss some of the processes that we went through, including a scientific panel, which you'll learn about in just a moment, as well as an overview of the definition of disability that we created. You'll hear a little bit about some pilot testing results from the states that we worked with, and as well as a couple of action items for you all to take away from today's conversation. There will be questions, time for questions at the end, so do feel free to pop questions in the chat or in the Q&A box. We will be monitoring those throughout today's webinar, so feel free to engage with us in whatever way you would like. All right, so to kick things off, I'm just going to give us a little bit of background on this particular project. The goal of this project was to build public health capacity to monitor the health and well-being of people with disabilities before, during, and after public health emergencies. So how we accomplish that is by developing, testing, and disseminating a definition of disability specifically for the National Syndromic Surveillance Program. And I do want to highlight that when I say that we're developing this definition of disability, we're not looking at tracking individuals with disabilities throughout the healthcare system, but more really looking on the impact on the group as a whole. Now, this is not necessarily a solution to every challenge for disability inclusion and preparedness, but this project kind of describes one tool in the toolbox to help support better outcomes for people with disabilities, again, as a group. All right, so let's talk through a little bit of what our process looked like for this project. We really tried to host an inclusive process as we developed these definitions of disability. So we started off by establishing and facilitating a scientific panel to help us give input on this. And there were a variety of stakeholders included in that scientific panel, including people with disabilities themselves. We really wanted to make sure that people with lived experience had a voice in this process. So we went through these conversations with the panel. We also did several stages of pilot testing of these definitions of disability that we're going to be discussing today. And that included testing at the national, state, and local level. You'll hear a little bit of those results later on in today's presentation. Now we're also working on disseminating and promoting the use of these definitions of disability. All right, so we hope that this project is really going to help improve outcomes for people with disabilities following emergencies, and improve ongoing surveillance efforts. So again, this is not a solution to every problem. There's a lot of larger systemic issues at play in this particular project. You'll hear us talk a little bit about that, but we're not going to be able to address them through this particular piece of work. Issues like accessibility, more inclusive planning, issues with medical records, insurance, billing, et cetera. Those are larger systemic issues that also need to be worked on, but again, we're focusing on one particular tool in the toolbox to help our jurisdictions at the national, state, and local level be able to better identify the impact of public health emergencies on people with disabilities so they can inform preparedness and response. So I do also want to note at this point that you'll probably hear us refer to syndrome definitions in this conversation. We are not discussing disability as a syndrome. That is just the terminology that's used in the context of this tool in the National Syndromic Surveillance Program. We refer to syndrome definitions, but we're not saying that disability is necessarily a syndrome. Okay. So again, the key here, the key takeaway for this project is really that we're hoping to improve outcomes for people with disabilities in public health emergencies. Disability is not comprehensively collected in medical records as a demographic, but this is really important information because without this identification and response to people with disabilities, they may be excluded from public health preparedness and response, which could exacerbate existing health disparities. So this project that we're discussing today is going to be a strategy to help us understand this until such a time where we might be collecting disability status as demographic information. So that kind of gives you the lay of the land of the project. And now I'm going to pass it to my colleague, Kelly, who's going to tell you a little bit about the National Syndromic Surveillance Program. Kelly?
Thank you, Annie. Right, so let's talk a little bit about the National Syndromic Surveillance Program. NSSP is a collaboration among CDC, federal partners, local and state health departments, and academic and private sector partners who have formed a community of practice. These partners collect, analyze, and share electronic patient encounter data received from emergency departments, urgent and ambulatory care centers, inpatient healthcare settings, and laboratories as well. More than 77% of U.S. emergency departments report to NSSP through their BioSense platform. This includes 50 states, Washington, D.C., and Guam. 75% of the data is received within 24 hours of the visit, so near real time. 6 million messages are received daily into the BioSense platform, and more than 2,000 registered users utilize the system, with an estimated 73.5% of the U.S. population as represented in the system. So this diagram shows a little bit about how NSSP actually conducts syndromic surveillance. As I mentioned previously, people seek treatment in a medical facility such as emergency department or urgent care center. They provide information to the clinicians, and then that medical facility sends de-identified data, including the chief complaint, why they're presenting at the emergency department, any diagnosis codes, patient characteristics, and location to state and local health departments or to data aggregators such as Health Information Exchange. That data then makes its way from the public health department or the HIE to the NSSP BioSense platform, which is hosted at CDC. CDC provides analytic tools, services, infrastructure, funding to health departments to make this possible, technical assistance and training, data analysis support, and collaboration on specific projects like the project that we're discussing today. The NSSP community of practice is a very important aspect to this whole project. NSSP conducts syndromic surveillance to help monitor the health of the public. They share data via the NSSP BioSense platform, share knowledge. We build skills via webinars, trainings, and work group participation, and collaborate to develop methods and respond to emergencies. So this is just one example of how NSSP data is used. There are many, many examples, but the CDC Heat and Health Tracker is a collaboration that brings heat-related illness and temperature, creates temperature maps that shows the rate of emergency department visits associated with heat-related illness per 100,000 visits. So the map that you see here is a representation of those visits per 100,000 organized by HHS region. And these are encompassed over the course of a week. So you can follow this link to get to this interesting aspect that utilizes the NSSP data. So I'm going to turn it over to Maggie to talk a little bit about the results from our scientific panels. Maggie?
Thank you, Kelly. We're going to start by talking about our scientific panel process. So in the process of developing this definition for syndromic surveillance, we engaged with a variety of stakeholders and experts in a scientific panel process, which was made up of approximately 60 representatives, including healthcare providers, members of the NSSP community of practice, state health agencies, people with disabilities, members from federal interagency work groups on intellectual and developmental disabilities, CDC-funded disability and health programs, disability policy consulting experts, and academia. And this group worked collaboratively to develop and refine this definition of disability over a series of 4 panel sessions that led to this final definition. So the purpose of the scientific panel was to decide on an initial disability definition for mapping to diagnostic codes, as well as work to identify existing algorithms for identifying disability with diagnostic codes, map those ICD codes to the chosen disability definition, and then continue to provide input on the syndrome definition, review pilot test results, and ultimately finalize this definition for the National Syndromic Surveillance Program. We did also want to provide an overview of really what the results from each of these panels looked like. So we had 5 panels in 1 smaller work group. And in panel 1, that group really worked to determine the use of statutory definitions of disability as the baseline for the definition, and work on focusing on domains of functional disability type rather than highly specific definitions. Panel 2 established some nuances around a definition specifically for intellectual and developmental disabilities, and determined that it made the most sense to create 1 sub-definition for that particular domain, as well as looked at including an existing mental health definition that already exists within the BioSense platform in this definition of disability as a reference material. Panel 3 took a deeper look at our learning disabilities domain and determined to rename that as specific developmental and learning disabilities, and worked on relocating ADHD, conduct disorders, and hyperkinetic syndromes to this particular domain. We also had a specialized work group that focused specifically on chronic conditions. This is because our chronic conditions domain was extensive. We're talking several thousands of medical diagnostic codes were included in this particular definition. And so that work group met separately to take a look at some of the challenges in testing that particular domain. And so that group determined that it made the most sense to format that particular domain as a supplemental product for states and jurisdictions to use to allow additional flexibility in the data processing, and then determined that the chronic condition domain would only be tested at the national level at this particular point in the project. Then our final panel, panel number 4, which wrapped up just a couple months ago, looked at refining chief complaint and keyword usage for each domain, and then discussed communication plans and potential dissemination barriers and strategies for this particular definition. And with that, I will pass it to Erica to talk about the definition itself.
Hi, everyone. Thank you for being here today. So now that we provided a little bit of an overview of NSSP, I'd like to dive a little bit more into how we developed the definition and what actually goes into it. So ASTHO originally started with key informant interviews to guide the development and provide key insights into how we should move forward with developing this definition over the following months. We then used an iterative search strategy to identify codes, starting with the International Classification of Diseases, version 9 and 10, ICD 9 and 10, as well as SNOMED codes. We started with existing definitions of chronic conditions and other disabilities through the Chronic Conditions Warehouse, and used the Americans with Disabilities Act regulations and documentation to identify initial set of conditions and diagnostic codes that would code for people with disabilities. We did a literature search to identify research publications which already have definitions for disability, and then used reports and documents from disability advocacy groups to ensure that we were capturing all of the potential conditions in this definition. And then finally, our last resource set was CDC documents and guidance. As Maggie already shared, we went through this process of looking at the definition over 4 scientific panels, 5 scientific panels in total. And those panels of stakeholders provided feedback on each version of the definition. So we initially presented the definition to the group in the second scientific panel and then iterated on it over time, given their feedback and the comments that they provided during those panels before and after. Then we did an initial national pilot testing of the definitions for chief complaint terms and additional keywords that needed to be included in the definition, and then did state local pilot testing, which I'll talk about a little bit more. We excluded medical conditions which are generally expected to resolve in under 6 months with treatment or with surgery, or are generally self-limiting acute conditions, for example, getting strep throat or having COVID. Few of the conditions occur in multiple domains, and we sorted these conditions into the best fitting domain. However, we did allow overlap amongst the domains where it was appropriate. The final definition includes one overarching definition for overall disability with 7 domains of disability underneath it, and that's represented in the blue boxes here. The 7 domains of disability include hearing, vision, mobility, intellectual and developmental disabilities, cognition and central nervous system disabilities, specific developmental or learning disabilities, and self-care. We also have 2 additional components which jurisdictions can use, including the existing definition for mental health conditions and an Excel sheet which provides all of the codes for chronic conditions and immune system disorders. Jurisdictions can choose to use that to identify how chronic conditions occur with disability in the NSSP system. To give you an example of what one of these domains looks like, I'll just talk a little bit about the hearing domain. This domain includes diagnostic codes for hearing loss, hearing impairment, deafness, Refsum's disease, cochlear implant status, acoustic neuroma, and auditory processing disorder, among others. We also excluded acute diagnostic codes for impacted earwax or ear infection, and also included exclusions for chief complaint terms, like things like denies hearing loss, which is a common term that's used by medical providers at the point of care. And to put this into context about how this domain specifically could be used within NSSP, we heard earlier about how NSSP tracks heat-related illnesses in the system. So coming from Arizona, where heat is an issue that we have every single year, one potential use of this definition is that you could look at heat-related illness occurring in individuals that have a hearing disability to determine additional communications that you might need to do in your jurisdiction. For example, if you're only providing extreme heat alerts in a verbal format, you might consider also using text-based format or other forms of communication to help support individuals with a hearing disability. I'd like to talk a little bit about our pilot testing results from our state and local partners. This map shows our participating jurisdictions from NSSP Community of Practice, which helped test this jurisdiction. And you'll see that 6 states are highlighted here. Each of the domains of disability were tested by the state and local pilot testers. And from this figure, you can see that each domain was tested at least twice, with some of them tested 3 times and one of them tested only once. The positive predictive value for the state and local pilot testers indicates the likelihood that the definition can successfully identify if people have the target condition or not. So this is a really important indicator for these definitions. At the state and local pilot testing, we had a wide range of jurisdictional PPV values based on the domain that was being tested and the jurisdiction, which quarter of the year that they were testing their results from. These low positive predictive values indicated that some draft definitions were too broad, and there was additional clarifications, exclusions that we needed to make. Overall, the state and local pilot testers determined that the definitions captured the intended cases that they were supposed to. However, there were clear false positives, including misspellings, variations, and negations, which would help make the definitions better. Recommendations from the state jurisdictions included additional enhancements, so including additional codes, removing certain codes or excluding specific chief complaint terms to make the definition more precise. Recommended negations, as well as additional keywords to include. All of those recommendations from the state and local pilot testers were included in the latest definition, and then the CDC did the national pilot testing results. And on this table, you can see each of the domains on the left and the national level testing positive predictive value. Through this process, the positive predictive value increased a lot. So now we have most of the jurisdictions over 90%, which is a good indicator that these definitions are doing a good job of capturing the intended definition. And with that, I'll pass it off to Annie to help with our call to action.
Erica, appreciate it. All right, folks. So just a couple of key takeaways that we wanted to leave you with as you consider the information that you've heard here today. So 3 things. The first and foremost is that collaboration is really, really critical to this work because people with disabilities, have unique lived experience. We really want to make sure that they are part of any decision making about programs and policies that may be created for them. So we really want to encourage folks to improve collaboration and coordination amongst all stakeholders with an emphasis on people with disabilities, but certainly also public health agencies, folks who work on it, including preparedness staff, your data staff, your NSSP staff, and healthcare providers. Healthcare providers are also going to be a really important partner for you here, especially your emergency physicians who will be a really integral part of collecting the data that we've discussed today. So it's really important that each of these stakeholders be used as a partner in creating solutions, that we report back information that we hear to all of them and work with them to create solutions to any issues that you might see. We also want to encourage folks to work to increase disability documentation in their healthcare records whenever possible. We need to have documentation to get accurate data for people with disabilities in the context of NSSP. So really need to make sure that that disability is a part of the medical record, especially the emergency department record. And then finally, we really want to make sure that folks understand and recognize that these diagnostic codes can really support public health's response to people with disabilities during an emergency. So understand the value of this definition and make sure that you can put it into action and report back to the stakeholders who need to be involved. So thanks very much for thanks very much for considering that. All right, so we're going to briefly turn it to questions now, and we'll open it up to folks. I think we have 1 or 2 in the Q&A box, but do feel free to drop them in the chat as well. So I know there is one here at the beginning. Do you classify long COVID as a disability? So this is a really interesting question, and certainly something that, I think is the science is still evolving around long COVID. So there's a couple of things here. The first is that NSSP has a larger community of practice that is also involved on creating definitions of disability, and they are actually working on a separate definition of long COVID. So that's not necessarily included here, but it is a part of the system as well. So let us know if you have further questions about that. All right, I see one other question here, or a couple other questions here. I wonder if the label should be high risk in terms of disaster in progress and post events, which would then be able to include pregnant people, recognizing the barred door has been on too long. Okay, so I just want to note here, there was a question about whether or not pregnancy was included in this particular definition. So it was not, although I would just want to recognize that pregnancy is part of the larger umbrella of access and functional needs, although it is not considered a disability. People who are pregnant have long-term or may have a short-term disability status, under like a legal framework, and they do have additional access and functional needs, but it is not considered a long-term disability. Now that being said, people with disabilities can become pregnant. So they would not necessarily be, pregnant people would not necessarily be excluded in the data here. So that's not something that that we've included in this specific context because pregnancy is separate from disability. But there is a larger umbrella of access and functional needs that particular group might fall under. All right, I know I've talked a lot there, so I just want to open up to my attendees. Anything else that you guys want to add about long COVID or pregnancy there? Okay, great. Hearing nothing, I see a question about environmental sensitivities. This can be a condition that greatly impacts individuals, especially during emergencies. So yeah, that's a great question as well. And I think, Erica, do you want to talk if we have any specific codes related to environmental sensitivity?
Yeah, I would just, I'm not thinking of any off the top of my head, but if, Deanna, if you wanted to give us a little bit more context on what you mean by environmental sensitivities, I can definitely identify if those are included or not.
Yeah, and of course, there are specific disabilities that may have environmental sensitivities as a factor, and those, of course, would be included under the specific medical codes. Great. Okay. All right. Will these queries be included as a new CC and DD categories in NSSP Essence? So we are working on, the next steps for this definition is that we're currently just working to refine a few last things with our CDC project partners. They will go through CDC clearance and then they will be available in NSSP Essence for you to use. So we are planning to keep the NSSP community of practice posted on when those are available, and will be available to support and discuss if you have questions on specific things that are included as well. All right. Okay. So another question from Gloria Khan here. Impressive PPVs at the national level. I understand that means that for IDD, 95% of persons identified through the syndromic surveillance system do, in fact, qualify for IDD. What about NPVs? Do you have a way of knowing how many people with IDD, for this example, are not picked up with this method? Yeah, I don't think we want to discuss a little bit more about those state testing results. Maggie, would you have anything else you want to add?
Sure, absolutely. Unfortunately, because the testing process for this definition and syndromic surveillance definitions as a whole is going based on currently available data on medical records in the emergency departments that are reporting through the NSSP Essence system, we don't have a great way for capturing NPV, which is why it's unfortunately not part of the current pilot testing process for these definitions. Hopefully maybe in the future one day, but unfortunately I wish that I had a better answer on that, but we don't have a good way of identifying how many people that do have or experience IDD were not picked up through this definition.
Thanks, Maggie, appreciate it. And Gloria, if you want to talk more about that with us, please feel free to shoot us a message after today's webinar. Okay. Is there a plan for documenting how jurisdictions are using these definitions when they become available in NSSP Essence? So there is a limitation on this in that we, ASTHO and Thought Bridge will be, our funding will conclude for this project at the end of July, so we will not be able to track this long term, but CDC will be supporting any long-term sharing about how these definitions are used. So that's something that I would say, we can see what comes, or we'll have to see what comes next after funding for this project, but not at this time. Okay. All right. So I think, Eric, I see you're responding to Dina, but just for other folks on the line, sounds like in terms of environmental sensitivities, we were thinking about scent sensitivities, sound, EMF, cleaning agents, et cetera, as this can impact people and disrupt their daily living activities. So that's a great observation. I just want to highlight as well that in several of our, in several of our definitions, our domains of disability, there are specific disabilities that would have those associated sensitivities. Those would be included. And we do also have our larger self-care domain and some disability overall pieces, or some other like larger disability related codes and keywords that would hopefully be able to capture someone who might have some of these non-specific sensitivities. So again, not explicitly like related to a list of environmental sensitivities, but those are pieces that are included in this definition. All right. Could you circle back on the subtypes of disability groups and discuss in more detail the reason mental health and chronic conditions are a different color? I may have missed it, but I feel like that wasn't fully fleshed out. Absolutely. So Erica, that was your section. Would you like to tackle this one?
Yeah, thanks for this comment. So there are 7 domains of disability, which are part of the overall definition of disability that we have. And then there are 2 optional components which jurisdictions can use to help supplement some of the work that they're doing. So a jurisdiction might choose to look at overall disability and then also identify how it co-occurs with things like mental health. We had a lot of back and forth in the scientific panels about whether mental health should be included in the definition, as well as chronic conditions and immune system disorders being being its own domain as part of the overall domain. And ultimately, with everyone's feedback, we determined that because NSSP already has an existing mental health definition, that it was best to keep that separate. And there is a capability within NSSP to look at both mental health and disability together. So it's not necessarily that you can never look at that but you can combine them all together to look at how it's occurring. As we talked about the chronic conditions and immune system disorders, over 2,000 codes, and adding all of those codes into the overall definition of disability would have made this definition very, very broad and extensive. And so it was decided with the stakeholder feedback to keep that separate as an additional resources that jurisdictions could use to identify how those conditions co-occur with disability. So both of these will be provided in the documentation and the guidance with links so that anyone can access them. And we hope that jurisdictions will use those supplemental resources to see how it co-occurs.
Thanks, Erica. Appreciate it. Yeah, lots of extensive work. We're trying to, make sure that we're working in collaboration with existing NSSP resources and creating tools that make the most sense for use in this context. So great. All right. So we have another question here asking how can we provide more details on how the PPPs were calculated? Maggie, have anything to add there?
Yeah, absolutely. So I'm happy to go a little more in depth about the kind of pilot testing as a whole. So both at the national level and at the state level, we worked to calculate some rough approximate ideal sample sizes that we were looking for each tester to pull from their pool of NSSP Essence data. And so each tester would go in and run the code that was developed and pull the first set of cases that met to that sample size. The sample size we determined was to look at 350 cases. And then our testers would go through for that definition that they were testing each of the 350 cases and do a line review. So they would go through each case individually, read the medical report, and either put it into a clearly, yes, this case meets this definition, clearly, no, it does not, or an undetermined bucket. And based on that, they would calculate the PPV. And I did see we have a question in the chat as well about PPV and NPV. So PPV is positive predictive value and NPV is negative predictive value. So that's how the predictive value was calculated. Each of our testers calculated that individually for their pool of data that they work with. So our stakeholders and partners at the national level tested on national level data, and then each of our states tested at their individual state level. So for example, our testers from California worked only with California data. They then each provided their positive predictive value and recommendations on how to improve that positive predictive value based on what they were seeing in the data, what things might be causing false positives to come through. And then those revisions were taken to panel 4, and a final round of testing was done based on those revisions to create new or take a look at new positive predictive values, how the definition has improved with those revisions, and the same process was used for that second round of national testing.
Right, fantastic. Thanks very much, Maggie. Appreciate it. And appreciate the ask for the clarification on the acronyms. Shouldn't make assumptions. So thanks very much. All right. So just a couple things that I know we answered some here in the in type. So I just want to make sure that we read those out for everybody. Is a brain injury considered a disability? Somebody asked. And yes, we do have that included in the cognition and central nervous system disorders domain. So those brain injuries are repeated. What I will highlight again here is that, we really focused on inclusion of disabilities that were long-term, not in the short term, for this particular definition as well. Okay, and then I think I saw one more question here about what's included. So an earlier slide indicated that about 75% of the population is captured in ED and urgent care, and the ideas of who is more than likely not to be included. So as Kelly noted here in the chat, there are particular health systems or emergency departments that don't report out to NSSP. So those are the folks that you would see not included in those in this data. Although there's obviously issues at play here as well of access to emergency departments and in urgent care as well. So those are folks that might not show up in this data too. So some of those accessibility issues, again, the larger systemic issues that kind of come to play in this definition are things that we'll have to look at other work to work around. Maggie, I see you came off mute. Do you have something you want to add?
Yeah, so I was also going to add that the link that Kelly shared there is a great resource, and it will also highlight there are counties in the US that would be considered not to have an eligible healthcare system for NSSP, which means that they do not have an ED or an urgent care. And a lot of times those are going to be our rural and frontier county regions. So there may be people living in very rural communities that don't have an NSSP eligible community or health center near them.
Thanks, Maggie. Appreciate it. All right. Well, I am seeing no other questions in our Q&A box. I will see if there's anything else, please, or if there's any last questions, we'll wait a moment to see if you have something you want to add in the Q&A box or in the chat. Although I'll also note here that we've got a comment in the chat that there are different coding practices among emergency departments, physicians, and per region. That's correct. So those are factors that can also influence the use of this definition too. So again, just really stressing the value of making sure that that disability information is included in these medical records whenever possible. Okay. Any last questions or a last call for questions, comments? Again, feel free to use the chat or the Q&A box. Okay, I am hearing none, so we will go to our wrap up. All right. Well, first and foremost, I do want to take a moment to thank you all for your time and attention today, and of course, thank our very knowledgeable and intelligent speakers today for their participation as well. So just a couple of things before we close out. I just want to note that we do actually have a technical assistance office hour scheduled for tomorrow. So if you're sitting on this webinar and you're having a couple of lingering questions or maybe some ideas are percolating, you want to have another conversation with us, we are available to talk with you tomorrow afternoon at the same time. So that's Tuesday, April 30th from 4 to 5 p.m. Eastern Standard. You can scan the QR code here on the screen, or you can click the link in the chat to get registered for that. We will be available on this office hour. So come prepared with questions or ideas, things you want to talk about. We can talk with you in that avenue, or you're more than welcome to schedule a follow-up conversation with us. We are available to support on this. So I'll just give folks a moment to scan that QR code or click the link. And the registration link is also available on ASTHO's website in case you lose track of it. Great. Well, we hope to see several of you on tomorrow's office hour. And then finally, I just want to invite you to fill out our evaluation. Again, you can scan the QR code here on the screen, or you can click the link that will be in the chat momentarily. And just a reminder here that we do actually read these. We want your thoughts, we want your input. We really value your perspectives on these events. So if you can just take a moment of your time to help us make these most valuable for you, we'd really appreciate it. And that's it for today. Thank you again very much for your time and your attention. And we thank our panelists for their time today as well. So thanks everyone and have a great day.